this morning with the sunshine in my eyes. Went to the mirror just to put on my disguise. Looked out my window and to my surprise I see you standing there looking back at me. Walking in this hallway where both ends are dead, exceeding the fathoms of the confines of my bed.
Welcome, and thank you for joining us today. The film you are about to see describes innovative tools, approaches, and techniques that can be used as alternatives to the use of seclusion and restraint in mental health care. Seclusion and restraint can result in injury and even death. They are practiced in a number of settings: jails and prisons, hospital emergency rooms, and psychiatric facilities, and often by staff who have not received adequate training on alternatives to their use. The good news is that many individuals and organizations are creating strategies that are effective in reducing and even eliminating such practices. Since the mid-1990s, there has been a general decrease in the use of these methods. More humane and more recovery-focused practices are available to protect both consumers and those around them. Providers of mental health services and facility administrators are asking for practical how-to information that focuses on collaboration and communication so that we can move from coercion to compassion. The video you are watching today, Leaving the Door Open, is a companion to Roadmap to Seclusion and Restraint-Free Mental Health Services, a CD-ROM also produced by SAMHSA. These materials offer exercises for staff training sessions and information about specific strategies that have proven effective as alternatives to seclusion and restraint. At SAMHSA, preventing and ultimately eliminating the use of seclusion and restraint is a top priority. We can view seclusion and restraint as not treatment, but treatment failures. Thank you for helping us achieve this humane goal.
Help! Help! Get me out! Somebody! This isn't right!
I remember I did nothing wrong. There were people in the seclusion room banging on the doors, yelling. There were people in the unit who were upset. I was terrified. Absolutely terrified. So I ran. The next thing I know, I was in seclusion. If only someone had listened.
We're leaving the seclusion room now and opening the door to communication. Our next segment is a role play involving conflict and resolution.
And I hate these psychoeducation groups, man. Why we even have to be in this group? We should be in arts and crafts.
What are we going to do in group today?
Maybe we can go outside.
I don't know.
Because
Do
the
whatever.
lights outside.
And see, just keep them occupied. They don't pay attention to anything anyway. Just look at
serious. I really do not want to be here. I mean, if I had my way, I'd roll up out of here.
Pay attention to anything anyway. Just look at her. She's already starting up now.
Okay.
I'd rather be in arts and crafts.
Whatever. Okay. Today we're going to have a psychoeducation group.
Man, I don't want to be in this group. This group is boring.
Hey!
I can't stand this group.
Where are you going?
Man, the group is boring.
Sit
we should
down.
Be
I don't care.
Hospital.
You know
I'm
what?
getting out of
You
here.
have to
I'm
sit
getting
down
out
now.
of here. I'm not taking that medication anymore.
We have
I'm
rules
not taking
here.
that. I don't
Listen,
care
we have
about your
rules.
rules.
Care what you care.
I don't
We have
care about
rules.
your rules.
You
Get
sit
your
down.
hands open. I don't have to sit
We
down
have
anywhere.
rules here.
Get your hands
You
off
are
of
going
me.
to go. I'm
Get your
here,
hands
you're
off
going
of
to
me.
go
I
to
don't care. You
seclusion
can do
now.
what you want to do. You better
Somebody
get your hands
call
off of me.
security.
You call you want to
security
call.
now.
I'm getting out of this hospital. I really gotta be outside.
Good morning, everybody.
Good morning.
And welcome to Recovery Group this morning. Today, what we're going to be talking about is what recovery means to each and every one of you.
And the food is terrible here. It's boring here. I can't stand it anymore. The food tastes horrible. I'm tired. I'm getting out of this hospital. I'm getting out of this hospital, and I'm not taking that medication anymore. I'm not taking anything anymore. I don't want to be here. I mean, you just don't understand. I just don't want to be here anymore.
I understand
You
you're
don't
not...
understand. You don't understand.
I understand you're not wanting to be here.
No, you don't understand. You don't know what the medication does to me. I haven't had any sleep, and it makes my mouth dry.
But you know what? Maybe we can go and sit down and talk about it. Maybe we can have something to drink. Huh? You know, and then maybe you and I can talk to the doctor together, maybe?
Okay.
Okay, all right. You tell me all about it, you know?
The medication makes my mouth.
Sharon, tell me how you felt in each of the scenarios.
Well, in the first scene, I felt that you all didn't care about me, and I felt like you weren't listening to me. I actually felt very threatened. It seems like the things that I needed and wanted from you all, they weren't there. You know, I didn't want to be in a group. I was new. I just didn't want to be there, and no one listened. And in the second scene, it appeared that you all cared, that you started to listen to me, that you started to identify with where I was coming from. You know, being someone that was new, I was having problems with my medication, and you actually told me, you and Michael told, you know, you let me know that you wanted to help me by going with me, not sending me alone to see the doctor, and I thought that was really important to me because I know that I need support. I know that I need someone there with me when I'm taking steps like that, especially things that bother me, like with the medication.
Malini, remember a year ago when I came to Elgin? We both, at just about at the same time, had the idea that we would do the dialogues in all of the units, but that we added this dimension of role plays.
I know, and you were scared and I was scared.
And you didn't tell me till the morning of how scared you really were about it. We both had an anxiety.
I had never done it before.
I know, neither one of us had. Because what we had done was to do the role plays between patients and staff together. And it really did work.
It worked so well that after we did it when you were there, we've incorporated into some of the things that we have been doing. We've been doing training for the staff on non-coercive practices. And we've done role plays with staff and staff or staff and patients.
It's really a very powerful tool.
Role-playing it's a really powerful technique, and it helps patients and staff understand each other's perspective. It also fosters collaborative relationships between patients and staff. So we can actually demonstrate non-coercive practices and discuss options with staff, and also show ways in which patients can increase their own responsibility towards recovery. And we have also incorporated into our community meetings. You know, the community meetings are once a week. So we have role-playing, and our recovery specialist actually takes part in it and helps, you know, the patients. You know, sometimes it's a little difficult for them, but she kind of facilitates it. And we also are incorporating it into our annual training for our staff.
Many hospitals have seclusion rooms they no longer use for that purpose and are converting them into comfort rooms, sometimes called other names, such as soothing rooms or calming rooms. Here are examples of some of these rooms that have been created in different parts of the country. Personal safety plans have become a useful tool. This is a form that creates a partnership of safety between staff and patients. Individuals are able to identify things that help, things like listening to music, wrapping themselves in a blanket, or reading a book. They are also able to identify what causes them to be upset, things like a loud voice, a person in uniform, or someone jangling keys. Special safety plans have been developed for children as well, with illustrations or pictures of what they might find helpful, a teddy bear, coloring books, or music, the kind they like to listen to.
What a treat to be here to talk about the importance of using humor. You know, humor actually has healing properties. When we use humor, it helps people de-stress, it helps them calm down a little bit. What we want to do is that we want to be silly, we want to be wacky, we want to help make the people we serve, children, adolescents, adults, even our team members, enjoy themselves. It really helps. You know, I've been to programs across the country, and I have met so many really compassionate and creative staff who really think out of the box. I was at an inpatient unit, and a young girl around 9 years old, history of sexual abuse, wouldn't come out of her room, didn't like to come out of her room. A staff member goes in, a big smile on her face, she's carrying a teddy bear, and she says, "Lydia, this is Tanya. Tanya really wants to go to community meeting, and I need somebody to babysit her there, to take her there and babysit her, because I have to go get all the other talented young'uns." You know, speaking of talents, I saw that beautiful picture you drew this morning. Would you please take Tanya for me? How many times do we just as staff say things like, "Community meeting now"? We need to use every interaction we have with a child, an adolescent, an adult who we serve. We used to use every time we talk as an opportunity for caring, for compassion, for being interested in them as a person. Every time we talk to somebody, could we notice that beautiful necklace, the little tiger on their shirt? When we have to give somebody a direction, could we, when we give that direction, also remember, "Oh, you know what? You did such a nice job. You were so helpful when Henry fell yesterday." Or when we have to give somebody a reminder about something, can we use that time? What if we used 1/5 or 1/10 of every time we talk with somebody just to remember them as a person, just to remember their special talents, what they're interested in, the food they like, a family member? What if? Did you notice the staff says, "What do you think? What do you want?" As important as all of us being creative and using humor and funny pieces is really the aspect of truly engaging, truly listening. And what about staff being good observers, really noticing what comforts the persons who we serve? What comforts you? What do you do when you're feeling stressed or anxious? Do you take a walk? Do you drink some tea? Do you go out and shoot some hoops? What is it that comforts you? And we need to begin to notice what are small things that comforts those we serve. In one program, serving adolescents, they had a lot of restraints before bedtime. And so what the staff and the adolescents did is they got together and decided to offer each adolescent 2 or 3 different tools that they could use to help them kind of calm down before bedtime. The kids chose CDs that they liked, that they could listen to. Some of them actually chose tea. Some of them chose going into their kind of sensory or comfort room where they could engage in different activities within that. What happened over the course of about a month is that restraints went down.
Many hospitals are trying to shift from a traditional model to a recovery-oriented environment. The psychiatry program where I was medical director did successfully eliminate the use of seclusion and restraint. But we didn't do that by learning better de-escalation techniques or different ways to intervene in violent situations or by using more medicine. Instead, we underwent a fundamental cultural change that created opportunities for better engagement and decreased occurrences of violence. A place to begin is during the admission process. Try changing the question from "What's wrong with you?" to "What happened to you?" Dr. Sandra Bloom, a Philadelphia psychiatrist who developed the sanctuary model, teaches that this essential shift assures our hope and belief in recovery.
I'd like to talk a little bit about the issues of trauma and trauma-informed care. For the last 10 years, I've been working on these issues, primarily around trauma, violence, and re-traumatization. I took a lead role in the 5-year SAMHSA-funded study that was called Women, Violence, and Co-occurring Disorders, where we created the evidence to prove that there was a great link and correlation. Actually, the numbers are staggering about how many people, women and men, end up in the hospitals who have trauma and abuse in their lives. And by trauma, when I say it, I mean anything that violates you, anything that hurts you so bad that you never heal from it, that you always meet it again and again. That's what I mean by trauma. There are many definitions, but if it's something that you don't get over, then I call it trauma. And one of the first issues in that study that we looked at was seclusion and restraints because of the work that was being done in Massachusetts. So we've gone a lot further since then. And right now, I want to talk about the fact that although many institutions, providers, however, systems ask the questions about trauma and being violated, they don't do anything with the answers.
Listening to people's stories, really hearing them, changed how I practice psychiatry and can help staff connect with those they are serving in a human way rather than in an us-them way.
We've had one really important success through the Joint Commission, through JCAHO. And they say consumers should be involved in the training, the restraint and seclusion training of their staff. And we're hearing from more and more facilities and consumers who've been faculty for this training. Staff really want to hear our stories.
Traditional mental health settings are full of triggering situations, and consequently, we have probably caused people we are serving to be disengaged or even aggressive towards staff who are acting as rule enforcers.
This would be now 30 years ago. I worked at McLean Hospital as a mental health worker. And we were taught very early on, once you start to work, one of the key things you're taught is how to restrain people as a team. And it was a process. I remember feeling very proud of our capacity to go into a situation where there was a worry that somebody was going to injure somebody or injure themselves. And we learned how to isolate limbs and to the whole process to grab people, put them down on the ground, transport them into the quiet room, and then get out of the quiet room without getting injured in the process, and hopefully without injuring the person. That was something I remember feeling that I'd learned a competency that was going to be useful to me. And I actually carried that thought with me for a long time into my training, and thought that all residents in psychiatry should learn how to do this. One of the consumers who I got to know very well invited me to come down to meet with a bunch of other consumers. This was actually Ron Gibson. And we went to People's Oakland and sat down, and Ron started to ask me questions about a variety of different kinds of things, as Ron would do. And at some point, the issue came up about, why it was that people didn't like to go to the hospital. And what they started to talk about was the idea that this whole process of seeing people get restrained had an impact in two ways on people. One was that, of course, they didn't like the idea that they might be restrained, that they would be, quote, gooned, that was a frightening prospect in and of itself. But additionally, there was this sense that they didn't like being in an environment where other people might be gooned, that the whole thing gave a sort of level of terror to being in the hospital. And I think it was both about the fact that there was a sense that people could be so out of control that they would have to be gooned, quotes, you know, or restrained, but it was also the whole process of watching people be actively restrained was frightening. So I began to think at that point, you know, this is really a trauma. When it comes to that, that's a trauma. And I hadn't really understood that I was, in fact, participating in a trauma as much as I was. I thought I was controlling a situation and decreasing trauma, but it flipped me a little bit.
There are many ways to increase the sense of control in those being served, including, of course, ensuring that they are partners or even leaders in their treatment planning. More and more hospitals are using peer specialists, people who are experienced in receiving mental health services and who are then employed by the hospital to act as advocates, consultants, and assistants to both staff and those being served.
I personally work on the admissions unit, which I get to see people when they first come through the door. I explain to them what peer support is, that I myself have been in the hospital, so I understand some of what they're saying and doing, and I'm there to help.
I meet with patients individually, talk with them about, they talk with me about what happened to cause them to end up in a restraint or seclusion and what they think that we could have done differently. And also, what could we do differently next time? Then we go into a clinical debriefing or a team debriefing, and
that
I facilitate,
right.
And I support the consumer, sit near the consumer to help, so that they have, to help them find their voice, so that they can say, this is what I think could, you know, they do treatment planning. This is what I think could avoid a restraint next time.
Other lessons from trauma-informed care include the application of customer service principles. Businesses have figured out that excellent customer service decreases anger, decreases violence, increases satisfaction, and increases engagement. Usually the focus is on how staff treat those they are serving, and that's important, of course. But the way that staff treat each other can play a big part in creating a feel of the environment. Now, most of us have probably been in the uncomfortable situation of witnessing two employees who are angry with each other or arguing, and that turns out to be a big trigger for people who have been exposed to trauma and violence. But probably just as powerful is when staff treat each other well. I first learned about this when I met a young woman who had been in the hospital for several days, but really hadn't been out of her room. But one day, she was out and about with her peers and with staff. I asked her how she was doing, and she told me she'd had a great day. I asked her what had made the difference, thinking she'd say, well, maybe the medicine had kicked in, or she'd had a great session with her doctor, or received an important new insight from a therapist. But instead, she told me the difference came when two nurses had arrived at work that morning, and she'd seen them greet each other. They'd given each other a hug. One had told the other, happy birthday. The young woman told me that their affection and obvious delight in each other helped her to feel safe on the unit, really for the first time. Now that's something that can be implemented with no impact on the budget. All organizations can use staff-to-staff interactions to create a hopeful, safe environment in which to heal. It all really boils down to treating others as we would all wish to be treated, both as people and as people receiving health care services.
We at Mayview State Hospital would like to express our gratitude for having been selected as the location for this video. Mayview, as well as the other hospitals in Pennsylvania, rarely use seclusion and restraint. We encourage you to do the same.
Woke up this morning, the sunshine in my eyes. Went to the mirror, just to put on my disguise. Looked out my window, and to my surprise, I see you standing there, looking back at me. Walking in this hallway, where both ends are dead, exceeding the fathoms of the confines of my bed, tracing the shadows, dancing in my head. I see you standing there, looking back at me. Sunrise, sunset, high in some afternoon, at night at the lights to reflect upon the moon. When it's gone, it comes round again too soon.